Hi, I'm Dr. Voss, one of the general urologists with the group. Thanks for joining in this evening to address solutions to bladder control issues. Just to start, some basic information regarding the urinary tract. Urine flows from your kidneys down to your bladder through tubes called the ureters. The bladder is basically just a big muscle, the detrusor muscle. In a normal state, it should be able to relax and allow you to hold urine and then contract to allow the urine to be expelled or released through the urethra. All parts of the urinary system must work together properly in order to control urination properly. A few different bladder control issues that people could have, one being overactive bladder. That is estimated to affect about 50 million people in the United States, which obviously a very common issue. Secondarily, urinary incontinence, which can be associated or run hand in hand with overactive bladder. And there are three types of urinary incontinence that we'll address this evening, one being stress incontinence, then urge incontinence, as well as overflow incontinence. And about 25 to 33% of people in the US suffer from urinary incontinence. So again, not an uncommon problem. So starting with overactive bladder. What is overactive bladder? It's basically just a constellation of symptoms. It's not technically a disease. The symptoms would be sudden uncontrolled need or urge to urinate. Indications that you might have overactive bladder would be if your bladder can't hold urine normally, if you develop this strong sudden urge to urinate that you can't control, if you're visiting the bathroom more than 8 times a day, if you have accidental leakage and that you can't make it to the bathroom in time once you get that urge to urinate, and then if you're waking up at night 2 or more times to urinate, that can be a sign of overactive bladder. As far as urinary incontinence, again, that's an inability to control your bladder, which again can present in 3 different ways. First of those being stress incontinence. That's leakage from the bladder whenever you have an increase in abdominal pressure or anything that puts pressure on the bladder. Commonly, we see this with coughing, sneezing, exercise, like lifting something heavy, shifting in body weight. Sometimes people will report issues when they go from sit to stand. And then sometimes with sexual intercourse or orgasm. That can be mixed, also run in line with urge incontinence as well. Stress incontinence is more common in women and often worse after childbearing. Urge incontinence is when you get the sudden strong urge to urinate and cannot control it. The bladder can often feel like it's squeezing or spasming, and you lose urine often en route to the bathroom. And for some people, urge incontinence really occurs. That's your only warning of bladder fullness, is that you're already starting to leak, and that's what gives you the urge to go. Again, that is more common in women. And then the third type of incontinence is overflow incontinence, which is quite different than the first two. That is when you leak or dribble urine because you are not effectively emptying your bladder. Your bladder is staying too full. And essentially, there's only 2 directions the urine can go, either back up to the kidneys or it will start leaking out the urethra because the bladder gets too full. And that can happen in both men and women, but we will more commonly see that in obstructive type issues, particularly in men with prostate issues. What causes bladder control problems? So again, normally the bladder it's a muscle, and so the muscle should relax to allow you to hold urine. When the muscle does not relax properly or it's overactive, that can cause you to leak urine without control. Anything that damages or weakens the detrusor muscle can cause a problem with bladder control. So below are several examples of things that could cause problems, being other diseases, sometimes medications. So bladder cancer, inflammation, or bladder stones, one of those. Other diseases like diabetes. Diabetes can affect the nerve supply to the bladder, which over time can affect both the nerves and the muscle. That can result in incontinence as well as retention and not emptying issues. BPH, or prostate enlargement, again, is men age. That can cause both overactivity as well as difficulty emptying that could eventually contribute toward the overflow type incontinence. As women age and go through menopause, estrogen deficiency will affect the quality of the tissues in the vaginal area, which can also lead to frequency, urgency, and incontinence issues. Herniated discs or neurologic problems are a major cause of both urge incontinence as well as potentially not emptying the bladder and leading to overflow incontinence issues. Medications, several different medications like water pills can definitely contribute to frequency, urgency issues. Common things that people, have drinking wise, caffeine, coffee, tea, soda can also irritate the bladder and contribute to urgency, frequency. Obesity, the extra abdominal weight puts pressure on the bladder, which makes it more challenging to fill. That can contribute toward urgency, frequency. Neurologic problems such as multiple sclerosis or Parkinson's disease, as well as stroke, often will cause urgency and overactivity. Pregnancy and childbirth can lead to a whole variety of issues. I would say most commonly we think of stress incontinence, the leaking with coughing, sneezing, straining. Urge incontinence, however, can follow pregnancy and childbearing, as well as sometimes retention, not emptying, and having issues with overflow incontinence. Radiation therapy, again, causes a chronic inflammatory change in the bladder, which will contribute to overactivity, urgency, frequency. And then any type of pelvic surgery can have a variety of effects. So common things that we would see would be like surgeries for colon cancer or, gynecologic type cancers, which will often cause either urgency or impaired emptying, which could cause overflow issues. And then UTIs very commonly cause frequency, urgency, and could contribute to urge incontinence as well. So how do we diagnose bladder control issues? A lot of different tests that are possible. Some of these are listed here. Stress tests are primarily to look for stress incontinence, so the type of incontinence that you get when you cough, sneeze, strain. This is a very simple in-office test that we do, ideally when the bladder is comfortably full. It's done by a pelvic exam. We take a look down at the urethra, typically in a female, but we also do this sometimes in men, particularly after prostate surgeries. And what we ask the patient to do is essentially strain, cough, or sneeze with that comfortably full bladder, and we are examining the urethra for any signs of urinary leakage at that time. Urodynamics is a little bit more invasive test that requires scheduling. We do that down at our offices in Norwood. You are awake for that procedure. It involves putting a tiny catheter into the bladder as well as a tiny catheter into the rectal area. We fill the bladder up with a saline or water solution, and we watch the bladder pressures as the bladder fills and as you try to urinate. And the goal of that is to see how much urine the bladder will hold effectively when the bladder starts becoming overactive or feeling full. And then again, we can do stress maneuvers during that test as well, where we have you strain, push, and see exactly when the leakage is occurring. If it's an overactivity issue or a stress incontinence issue, we can also look to see if the bladder's squeezing or not squeezing, if it's if it's wanting to be too full and not empty properly. Cystoscopy is a minor procedure that can be done awake or asleep, where we put a tiny camera into the bladder to examine the internal lining of the bladder, make sure that the internal lining is healthy, that there's no signs of anything bad, like a bladder cancer, bladder stone that would be causing the issues. Not everybody with bladder control problems needs that test, but it would be indicated on a case-by-case basis. Oftentimes helpful for, if we're concerned about an obstruction or some sort of pathologic cause for the incontinence or overactivity. Urinalysis, again, a very basic in-office test that we do on pretty much everybody at the time of an office visit. That primarily is looking for infection and blood in the urine that could be a sign for something that requires more investigation. And then a post-void residual volume, again, is a very basic in-office test that we do to see how well you empty your bladder. It is essentially a little ultrasound. So we just put a little jelly on the lower part of the abdomen and use an ultrasound to measure how much fluid remains in the bladder after you urinate. And primarily they're just making sure that the bladder is emptying effectively, that there's not an emptying issue. Additional test, ultrasounds of the bladder, again, a non-invasive test that we can do that takes actual pictures, ultrasound images of the bladder to make sure that there's no irregularities. That can also be used to look for emptying, and that is something that has to be scheduled at an imaging center. CT scans can also be done. I would say not commonly for this particular, for bladder control problems, unless we are concerned about some kind of pathology. But that would take a nice 3-dimensional picture, X-ray pictures of the bladder. EMGs are basically just to look for muscular and nerve activity near the bladder. Typically, they're done in association with the urodynamics test. We'll use little patches around the rectal or gluteal area to measure muscular contractions in that area at the time of bladder filling and bladder emptying. And then PSA blood tests will be for male patients with overactivity or incontinence issues as a screening test for prostate cancer, typically done in conjunction with the rectal exam. Bladder diaries are also extremely helpful for people with overactivity. So what we're looking at there is essentially just a track record of how many times a day that you urinate. Typically, we'll give you either a urinal or a hat to place in the toilet, where we have you urinate into that device during the testing to measure how much volume is produced with each urination. We also look at fluid intake during the test. And again, this is a test that's typically done at home. It's patient reported. But what we want to see is, if there's something dietary-wise, fluid intake-wise that could be contributing to the frequency urgency. Are you drinking a lot of caffeine? Are you drinking very high volumes of water? And then we look at the urinary output to see, if you're producing very small volume, frequent urinations, that is definitely a sign that the bladder doesn't want to hold urine effectively. And then we have you rate urgency values with that too. So this is just, again, a nice little tool that's non-invasive that helps us kind of distinguish what's causing the bladder control problems. A copy of that can be obtained on the Urology Group website for completion, prior to appointments. In terms of treatment of overactive bladder, many different options with least invasive to most invasive, and we'll kind of go through different treatment options together. So this slide is just to kind of let you know there's lots of different options for treatment of overactive bladder, and not to give up if something doesn't work. It's certainly worth a repeat evaluation or repeat office visit should that be needed to discuss next steps. So the first thing that we'll often try are lifestyle interventions. That can be things like altering hydration habits. So I will frequently tell people, we want you to be hydrated. We don't want you to restrict water intake, but making sure that you're drinking water in smaller quantities more frequently throughout the day to evenly space it so that you're not drinking a whole bunch all at once. That's going to contribute toward, frequency, urgency type issues. Dietary adjustments. So again, avoiding irritant things like caffeine, coffee, tea, soda can go a very long way at avoiding overactivity. Exercise and weight management. So again, abdominal obesity can contribute toward urgency issues by not allowing the bladder to fill. So maintaining a good ideal body weight is helpful there. Bladder retraining and pelvic floor strengthening, I would kind of classify in the similar category. And I think actually very helpful for people to work with a pelvic floor physical therapist on those things. Pelvic floor physical therapy is a subset of physical therapy devoted to the pelvic floor, which can help with both relaxation as well as strengthening exercises that help reduce feelings of urgency, frequency, and can often help improve or cure stress urinary incontinence. So that can be very helpful for a variety of different urinary control issues. Medications. Medications for overactive bladder essentially relax the bladder muscle so that your bladder can hold more urine before you get the urge to urinate. The intention of them is to allow you to go less frequently, have less urgency, go less often. Most of the bladder medications nowadays are taken once a day, but there are still several that we will offer that are taken 2 to a maximum of 3 times a day. Trouble with them, some medications act a little faster than others, but there are 2 agents that can take up to 4 to 6 weeks before you really get a benefit. So that can be a little bit of a wait period. The other issue with medications, as with any medication, a lot of bladder medicines have multiple side effects. The majority of bladder medicines cause things like dry mouth, dry eyes, constipation, so that can be difficult to manage. With prolonged usage, several of them can cause memory issues similar to a dementia, and that typically develops over the course of years of usage, but certainly something to consider before starting. And then there are newer agents that are more favorable from a side effect standpoint that can be difficult to obtain from insurance standpoint. And one of those can cause high blood pressure. So that's something that we monitor when you're on it. There are a variety of different procedures for treating overactive bladder. So we'll just kind of go in order of those. One option is sacral nerve stimulation. This is where we implant a tiny pacemaker device for the bladder. It takes essentially 2 procedures in order to put that device in, and it's implanted near the tailbone. And essentially we put a tiny little needle stick into the lower part of the back, again, near the tailbone, and we can feed an electrode down to the nerves that control the bladder. And that during that trial phase of the device, we'll kind of see if it actually works for you. If it does provide a greater than 50% relief in the symptoms that you're experiencing, then we can actually implant a battery through a tiny incision above the buttocks. So then all the wires and battery are internal. If it doesn't work, then the second procedure is to remove the wires so that we're not leaving anything permanent behind. Very nice procedure, minimally invasive. It sounds like a lot to go through, but it's very minimally invasive. 1 tiny little needle stick and 1 tiny incision. The benefits of the device, it can last up to 10 to 15 years. And then after that, the batteries do need to be replaced. But it's highly effective, like 85% effective for patients. So, and the nice thing about it, again, for younger patients, it lasts for 10 to 15 years without need for replacement. So that's pretty nice. And very low risk. We're implanting a foreign body, so there's always a chance of infection, but that's extremely low chance. And the nice thing nowadays, they are MRI safe. That was not always the case, but now they are MRI safe. So all the devices we're putting in now, you can go through an MRI scanner if you needed to. Next would be posterior tibial nerve stimulation, PTNS. This is an even less invasive option. I would say probably less effective and definitely more time intensive. This is done in the office, so no need for any type of procedures or anesthesia. We use a little needle or a device that we put just above the ankle, and we stimulate the nerve that runs there. It's the same nerve that will actually control, or the same nerve root that will control bladder functionality. So it essentially, the stimulating that nerve at the ankle level will send signals to your bladder that tries to calm the bladder down to help you hold urine better, go less often, have less urgency. The trouble with it is it takes 12 initial sessions for treatment. Typically, we see you once a week for 12 weeks. And then thereafter, probably monthly maintenance sessions. And each of these sessions can last up to 30 minutes. So again, no anesthesia. It's it's an office visit up to 30 minutes at a time, but a lot of office visits that are needed to maintain that, and probably less effective than some of the other strategies. The other option would be bladder Botox injection. That is a procedure that we typically do asleep. You can be awake for it and use local anesthesia if desired. But we put a small scope directly into the bladder and we inject Botox medication directly into that bladder muscle. And the purpose of that is to partially paralyze the bladder muscle to reduce some of that overactivity. So again, to help you hold urine more effectively, give more warning, go less often. That procedure is very nice because there's no external cuts, no incisions, but the problem is it doesn't last for forever. So Botox will wear off in about 3 to 6 months in most cases and need to be repeated. So it's a nice option for people who don't mind going through, multiple procedures. For younger people who have many, many years of treatment ahead of them, it may not be the best option just because of the repetitive nature, but certainly I think a good option for many. Then the other potential con of it is that if it works too well, there's about a 7% chance that you would not be able to urinate afterwards and need a catheter temporarily, which again is an effect that will wear off over time, but it can take a month or two for that to completely wear off. The last procedure is pretty significant. I would say very uncommon that we would recommend this for people. But a bladder augmentation is a major surgical procedure where we would actually use a patch of intestine to attach to the bladder and essentially increase the bladder capacity, the bladder's holding ability. So that's a major abdominal surgery, and problem with it being that a lot of times people do not spontaneously urinate after that. You're reliant on self-catheterization. But again, it would just, the goal of it would be to help you hold urine more effectively going forward, go less often, get more warning. But this is a very uncommon approach to treating overactive bladder. And at this time, I'd be happy to answer any questions that people have regarding bladder control. So one question coming in about which medications are associated with forgetfulness or memory issues. So an entire class of medications called anticholinergic medications are ones that we are now finding are associated with cognitive impairment, memory issues similar to a dementia. Those will be medications like oxybutynin, tolterodine or Detrol, trospium or Cinctura, Toviaz is another one, Vesicare or sulfafonacin. And again, typically an issue with prolonged usage, people who have been on these for many, many years. Another question regarding the use of Zevia tea and if that could be a problem for the bladder. I'm not familiar with the components of Zevia tea. I would definitely recommend seeing if there's any caffeine content in it. That could certainly, primarily we're worried about caffeinated beverages when we talk about bladder control issues. So I would just look at the components of that tea and see if there's caffeine in it. If there is, that could definitely cause problems with the bladder. Diabetes in and of itself could definitely cause problems with the bladder. There are some bladder medications that, diabetes medications that can cause problems with the bladder. Medications that cause you to spill sugar over into the urine can be problematic. And then a question regarding what are my options if my prostate has been removed? So the most common thing that we see after a prostatectomy surgery would be stress urinary incontinence. So options for that, if the surgery is recent, like within the past year or so, I would definitely recommend pelvic floor physical therapy. And again, we are happy to provide referrals to groups that specialize in that, but we will often use a group called Oxford Physical Therapy. And the physical therapist there would help try to strengthen the pelvic floor to reduce some of that leakage when you cough, sneeze, strain, which again is the most common issue that occurs after prostate removal. If that's not been effective, or it's been quite a ways or quite a while, several years after the procedure, you could be looking at more surgical type options, which there are several for that. There are male sling procedures that can help with stress incontinence, and there is an artificial urinary sphincter that can actually help with male incontinence after a prostate surgery. And which you're a candidate for would depend upon severity, and definitely would recommend, an office visit to see what you would be a good candidate for there. There's a question regarding insurance coverage for medications. I would say most bladder medications these days are covered by insurance. There are two newer agents, Gemtesa and Myrbetriq, which unfortunately are the two probably more favorable from a side effect standpoint. Those have kind of patchy coverage. It's very insurance dependent. It often takes our office just trying to see if we can get it covered for you. But the majority of the other medications are covered. The procedures kind of depends on the insurance. I would say for the most part, they are covered. A lot of times insurance companies will require that you try at least one medication before proceeding on to a surgical intervention, though. So that can be a little limiting. Question regarding physical therapy for bladder urgency and how does that help? That's a great question. Again, the physical therapists are trying to help strengthen the muscles that control the bladder, the pelvic floor. And so by strengthening those muscles, we can sometimes reduce urgency leakage as well as suppress urgency sometimes. And sometimes the suppression is actually a really huge thing for people, just trying to learn how to go less often, suppress the urge when it occurs. But the physical therapists are a wonderful resource for that. I highly recommend it. The question regarding how long to try lifestyle changes before moving on to other options, I would say that's very personally, it's kind of a personal decision, really. I think it depends on how bothered you are by the problem. If it's a really severe amount of incontinence, wearing multiple pads, soaking through clothes, you may not want to give as much time for just lifestyle intervention and move on to something more aggressive to give more relief. If it's a more mild issue, very mild amounts of leakage, I would say you have, more time to try physical therapy and medicate or, potential weight loss or other things that we can do. Question regarding if you can use overactive bladder medications along with medications that cause you to go to the bathroom more frequently. That's a great question. Specifically in this question, diabetes medicines. Absolutely, they can be combined. We'd have to look at an individual basis to make sure there's not a drug-drug interaction, but you can combine them. We see this a lot for people that are on diuretics, like water pills, that will make you produce more urine, so you have to go more frequently, more urgently. You absolutely can combine overactive bladder medications with water pills. It sounds counterintuitive, but it's not. The bladder medicines are not making you not produce urine. They're just making your bladder hold it better. So they're not counteracting. Okay. Question regarding tips for strong urge to urinate, but you're producing a weak urinary stream. That could be a definitely more complicated issue. Sometimes that occurs because your bladder is so overactive, it's not holding urine properly. You get a strong urge despite very low volumes being in the bladder. That could be treated by run-of-the-mill, overactive bladder medicines or dietary restrictions like caffeine restriction. Other things, though, would be potential for an obstructive pathology like prostate enlargement that could be causing you to feel urgency, but then the stream is weak because it's blocked up by the prostate. And that I would definitely recommend an in-office evaluation so we can get to the bottom of that. And we would definitely want to do bladder scan to assess for emptying and potentially even avoiding diary to see, urinary habits, how much urine is being produced. few questions regarding prostate enlargement, if that can contribute toward urgency, and if TURP surgery for BPH is likely to help with bladder issues. Excellent questions. So absolutely, obstructive issues with the prostate can cause both overactivity as well as incomplete emptying issues that contribute to frequency. So depending on, again, very individual situations and circumstances, I do think, prostate surgery like a TURP or a UroLift could be helpful in these situations. It depends on a case-by-case basis, but I think it could be helpful. There are some potential cons to prostate surgery in terms of, after effects that could cause either temporary or permanent increases in frequency, urgency as well. So that's something that needs to be talked through before deciding. But certainly I think it can be warranted in certain instances. Questions regarding question regarding the use of Viagra, which is a bladder control medication. If you've not been seeing a result after 3 months of continuous and routine usage of that medication, I would say no, it is not going to be effective. And unfortunately, with that medication, that is the maximum dose. There's no increasing the dose of that medication. So options would be the addition of a second medication with it, or talking about what we call the third line therapies, the more procedural type stuff with either the bladder pacemaker or the bladder Botox. Question regarding the bladder pacemaker procedure and how often patients come in for checkups. That's really dependent on the patient and how well you do with the surgery. Typically, we'll do a wound check after the procedure about 2 weeks after. If everything is going great, you don't require routine office visits, usually just like a once a year to check in, make sure that the battery is still functioning. The nice thing about that procedure too is that you get in contact with a representative from the company, the device company, that you have access to. You can call the company as well for any like troubleshooting issues and programming issues with the device. So it does not require constant, in-office care or assessments. A lot of it can be done electronically, virtually over the phone. If things are going well. If there's need for adjustments, then it does require some extra visits, but I would say mostly it's low burden. Someone asking regarding being triggered to urinate when water is running in the shower. I would say different people report different triggers for their bladder overactivity and urgency, and water running is definitely a common one. There's the question there regarding postmenopause. It's certainly possible that, postmenopausal vaginal changes like dryness could be contributing to the issues. Again, I think having it in an office assessment could help define. Sorry, there was a technical issue and my system kicked me off for a second. But so yes, I would say definitely an in-office assessment to see if there's something that we can do to help with that. All right. Well, I think that seems to be it for a lot of the questions, but I appreciate everybody joining in tonight for this webinar. Hopefully it was helpful. If anything else comes up, certainly make an office visit and we can hopefully address your concerns in person. Have a lovely evening.